common side effects of spending so much time on toes is short tissue changes, especially in the gastrosoleus complex, leading to plantar flexion contractures. And this is often also associated with dorsiflexion weakness. Treatment for idiopathic toe walking can be nothing depending on the patient. Some patients resolve spontaneously. Physical therapy often looks at strengthening and stretching the dorsiflexors. Serial casting, AFOs, and night splints also work on that dorsiflexion range of motion. Botox can be used with casting because it temporarily allows the muscles to be stretched. And the last resort is Achilles tendon lengthening surgery for those kids who just really have contractures that won't stretch. So meet my patient, JS. He's a 10-year-old male whose mom reports he has always walked on his tiptoes. And he learned to walk around age 1, so he developed pretty normally. He has no pain in his legs, and if you ask him about it, he says he has a little tightness in both of his calves. Last November, he went to his primary care physician regarding the toe walking. He was evaluated and sent to physical therapy and also given bilateral night splints to help him achieve dorsiflexion. He has no history of development or neurological issues. All of his exam findings were also normal, so he was diagnosed with idiopathic toe walking. So my first question was obviously, he's 10 years old, and why has he not been treated for this yet? And what I found talking to him and his mom is mainly, they never saw it as limiting. It never really bothered him until he got to this age of 9, 10, when little boys really want to play sports. He was really into basketball and baseball, and he couldn't run. He couldn't really move efficiently at all, so he couldn't keep up with his friends. And he couldn't especially play sports at the competitive level, and so that's when they decided to go to a doctor. He really liked video games, and so that's what he spent his time doing, and this was also causing him some social anxieties, him to gain some weight, causing him some other problems, all resulting from the toe walking. So at his initial eval last November, my CI administered the lower extremity functional scale. He scored a 41 out of 80, so it put him at about 50% disabled. And it's very important to note the lower extremity functional scale is not a pediatric outcome, so the validity for JS is not really known. He had developed plantar flexion contractures in both legs, and we can see he is lacking about 20 degrees of dorsiflexion in both ankles, and also has some dorsiflexion weakness. 7 months later in June, he was discharged just before my clerkship ended. We see that his dorsiflexion range of motion and strength really has not changed. He maybe gained 1 degree of range of motion, but as we know, the interrelated reliability is about 3 to 4 degrees, so we can't even really count those as gains. His lower extremity functional scale score did jump significantly up to 77, and we're not exactly sure of those gains. Maybe he figured out he could do more, but without changes in dorsiflexion and talking to him, he still couldn't do what he wanted to do. So we're not exactly sure where that change came from. The interventions we performed with JS, we would always start him on the bike. It was something he really enjoyed, some general exercise, warming up his soft tissues. We would do therapeutic exercise, trying to do obstacle courses, make it fun. It was all focused on dorsiflexion, strength, and range of motion, so activities like squatting, getting him to step over large objects, leading with his heel. But really 75% of every treatment session was spent with him lying on the treatment table while we passively stretched him and performed joint moves on the ankle, all in hopes of getting some kind of stretching in that dorsiflexion, some kind of soft tissue changes for him. He did have a home exercise program and continued to wear his night splints. It was mainly just stretching exercises that he did at home. And so he really struggled with enthusiasm and motivation because he wasn't engaged. He would lay there and watch TV or read a book or do something while we worked on his feet. And he wasn't getting to play sports. He really wasn't getting to do anything he wanted to do. He wasn't seeing any gains from this either. So he really wasn't motivated to be there. And that transferred over to the exercise and home exercise program as well. So I was thinking about the next step for him because he needs that dorsiflexion. You need at least 10 degrees of dorsiflexion to achieve heel-toe gait. And he was here 7 months and made absolutely no changes in his range of motion. And so looking at the clinical practice guideline and some of the other evidence and talking with my CI, it seems like the next step for him really would be to get Achilles tendon lengthening surgery in both of his legs. All the research out there seems to stop at the surgery. They don't really look at after surgery. It all seems to be, oh, well, if we give them the surgery, we lengthen the tendon and they have the dorsiflexion, they'll just start walking heel-toe gait. But I was thinking about it, and even though idiopathic toe walking by diagnosis is not a neurological disorder, he's been walking this way for 9 years, and his brain has been trained to walk on his toes. It's not just going to turn off because he has surgery and we give him this dorsiflexion. He's not just all of a sudden going to decide to walk on his heels. His brain just isn't going to assume that normal gait pattern. And so that's what led me to my Pico. In a 10-year-old patient with idiopathic toe walking that requires surgical intervention, does a neuromuscular approach post-operatively, compared to a range of motion approach alone, reduce frequency of toe walking? So my first study looked at 14 patients who all developed plantar flexion contracture and required Achilles tendon lengthening surgery at about 9 years of age. They all did a 3D gait analysis pre-op and about a year post-surgery. They all had casting 4 to 6 weeks after surgery to allow for tissue healing, and it said they had some stretching exercises post-surgery, but that's all the specificity they gave to that. They measured range of motion, and after surgery, they all had dorsiflexion within normal limits, which was a significant improvement. Looking from pre-op to post-op, they had significant improvement in dorsiflexion at initial contact and through stance and swing phase and gait. But looking at those post-op improvements compared to normative data, they were still significantly limited at initial contact and through stance and swing phase. They also use an outcome tool called the normative index, which looks at 16 characteristics of gait, and their score went from 82 to 28, which was a very significant change, and was just above the normalcy score of 21. So the conclusions of this study were that the surgery was successful. They now had within normal limits for their dorsiflexion. They had at least the 10 degrees needed to achieve heel-toe gait, but they weren't using it during their gait. So they had it, but they weren't using it functionally. Looking at the quality of this, some of the strengths is that it was very recent, and they had good comparison to normative values. It was a small sample, and the PT details after surgery were not included, so it's hard to know exactly if there was anything else that played into their treatment. My second study is effects of motor control intervention for children with idiopathic toe walking. And it was a case series that looked at 5 children between the ages of 2.5 and 6 years old. They had intervention for 9 weeks and 2 follow-ups a week after and 4 weeks after. They did a lot of functional training, a lot of gait training, and they also did a lot of sensory work with these children. It's very important to note they deliberately made sure there was no passive stretching in their interventions. The outcomes they used were a gait event detector that went in the shoes. It just went in the heel of the shoe and would measure every time they hit their heel on the ground. They also used a visual analog scale at home where the patients would weigh the percentage of time they spent using a heel-toe gait versus a toe gait. They also measured their dorsiflexion, and they looked at their gross motor quotient using the Peabody Motor Development Score. And as you can see with these numbers, there were some of the kids who had significant improvements in these various outcomes. The conclusions from this study were that some of the kids had improved voluntary heel-toe gait, but there really weren't that many changes in spontaneous heel-toe gait. And what this showed is that they had the potential in their systems to achieve heel-toe gait, but either there wasn't enough time or the specific interventions weren't correct in order for them to actually achieve spontaneous changes. But they had the potential to make those changes if the conditions maybe were different, but the habits were too strong for this particular study to have an impact. Again, it was a very small sample size, only 5 kids, and the case study is a low level of evidence. The visual analog scale also has a low validity. It's also very recent. It was done in 2010. It was very, very detailed in their treatment, and every kid had exactly the same treatment. And they utilized an independent physical therapist as a rater. So did I answer my Pico? It seems that physical therapy focused on retraining the neuromuscular system is more effective on breaking the habit of toe walking. Range of motion is certainly very important, and you need it to achieve heel-toe gait, but focusing on range of motion alone is not enough to get the functional changes and have these kids begin walking with a heel-toe gait. So you need more than just surgery or more than just stretching alone in kids that don't need surgery. You need to retrain the whole system in order to get these changes. But the exact timeline and interventions specifically are not clear yet. So if JS came back to me after he got his surgery, I would definitely take a neuromuscular approach. I would want to do a lot of gait training. Specifically for him, I'd want to do a lot of sports skill training since that's what he would want to do. I'd also want to see how he would respond to sensory work because for 9 years he hasn't felt anything on his heel or the bottom of the back of his foot. So I'd want to see how he would actually respond to that. And additionally, I'd also want to look at the rest of his lower extremity range of motion and other postural deficits he has throughout his body since we were so focused on the ankle. I looked at 2 different questions for my value for JS. One thing was, should he have been in our clinic for 7 months? I feel like he might have been better if he had been referred out for a surgery evaluation earlier on, either by the primary care physician or by the PT, maybe after 4 to 6 weeks of initial physical therapy, because physical therapy would be more beneficial to him after surgery because of the severity of his problem. And going along with that is cost. If he only had so much money available for physical therapy, we might have used it all up for the year. And now he goes to get surgery, tries to come back, and we can't help him. And so he'll revert back to toe walking, potentially have to get more surgery, more problems. We don't know for sure, but we don't want to use up all the money. And also, he fell through the cracks in the system. Somehow we missed him until he was 10 years old. And that makes it a lot harder to treat. That affects his quality of life. That affects healthcare costs. And so where does the physical therapist have to be in the system to catch him at age 3 when it's easiest to treat him? When he wouldn't have had to wait for so long and have missed out on so many opportunities as a kid. And it would have been a lot cheaper to treat him as well. And I don't necessarily know where that is, but it's an important question that we need to ask. So there are my references.
Oh my gosh. Well, there's a case for some health and wellness screening. Do you have a question?
Awesome job. This is fantastic. I'm loving this topic. Was he in the public school system?
Yes.
Has his mom remembered anybody in that system ever saying maybe that she looked at?
Not that I talked to her about. And I'm not exactly sure his whole health history. We kind of talked about it briefly, and I'm sure at some point it was either mentioned that they knew that he walked, like it wasn't that they were oblivious to it, they just didn't see it as a problem. They were like, oh, he walks on his toes, so what?
And had he seen a neurologist?
No. But he didn't have any other issues or any other signs, yes.
What makes the difference in people like your patient and others that toe walk that can play sports and actually do really well with it?
Probably the severity and the soft tissue changes. He had such a shortening in his gastrocnemius soleus that he was just